Hi, everyone. My name is Maria Picconi, and I am mom to an 8-year-old daughter named Taya, who has Prader-Willi syndrome. Taya was also recently diagnosed with narcolepsy, and today we're going to talk about recognizing sleep-related symptoms of Prader-Willi syndrome. I'm also the co-founder and CEO of a digital health analytics company called Tween Community, and I've been working with Dr. Glaze and his colleague, Dr. Amy Ravana, who unfortunately couldn't join us today because she just gave birth to a baby boy yesterday. So we're super excited for her. I'm gonna go let the panelists do a brief introduction for themselves. So Dr. Glaze.
I'm Dan Glaze. I'm medical director of the Children's Sleep Center in Houston, Texas. I'm the stand-in for Dr. Ravana. It's good to see you all.
Christy.
Hi, I'm Christy Rickenbach. I am the Parent Support Coordinator at PWS USA. I'm also the mom to Justice, who happens to have Prader-Willi syndrome, and she is also has cataplexy and narcolepsy, and she is joining us today also. So sitting next to me here, hopefully she doesn't disappear, is Justice.
Justice, go ahead. Want to introduce yourself briefly?
Hi, my name is Justice Faith. I had narcolepsy and cataplexy.
Thank you. How old are you?
I'm 17.
17. Thank you. Also dear friends of ours. All right, I'm going to share my screen. All right, and I'm going to start this slideshow. As I mentioned before, I am the co-founder and CEO of a digital health analytics company called Tween Community. And I started Tween along with my husband after our daughter Taya was born and diagnosed with Prader-Willi syndrome. Like many of you, we spent several months digging through the medical literature, trying to understand what this diagnosis meant for our daughter. And then we were lucky enough to pretty quickly find a group of caregivers on social media, a Facebook group called Living Well with Prader-Willi Syndrome. I'm sure many of you are also members of that group. And at that moment, really, that was the first time that we had hope for Taya. And we started to realize that there was a big gap between what was written in the medical literature and what we'd been told to expect from our doctors and what was actually possible. And Chris and I, we'd been working in digital health and clinical research for many years and had just started another analytics company. And we thought, you know, what if we could develop, use social listening and AI to turn those conversations on social media into data. And in the very beginning, we really just wanted to do it for ourselves to understand how to best manage PWS for our daughter Taya. And we really have leaned on the anecdotes from the community over the years to understand how to manage her diet, what sort of symptoms to look for, what specialists to seek out, and all kinds of things. And now Tween has grown. We've done these analytics projects with more than 30 communities. We've published on our data. Lots of exciting things have happened. So this is just an interesting sort of a why trend. So we believe that we can't be constrained to looking for answers where we think they should be, and we need to start looking where the answers are likely to be hiding. And this type of observational bias is called the streetlight effect, and it refers to an old joke. One night, a policeman found a man searching for his keys under a streetlight. He joined help only to realize after hours of searching that the man had lost his keys in the park. Then why are you searching here? Asked the policeman. Because this is where the light is, replied the man. Noam Chomsky, who's a very famous linguist, once said, science is a bit like the joke about the drunk who is looking under a lamppost for a key that he's lost on the other side of the street, because that's where the light is. It has no other choice. So I think this speaks for itself, but this is our purpose for turning on more lights by analyzing our conversations on social media to see if we can gain a little more perspective into, you know, what's happening within our community. So a few years ago, actually now, we did a social listening project with the Living Well group and also with another group for caregivers of children between the ages of 0 and 2. And what our social listening turned up is listed here on the right. These are kind of the top concepts related to burden. So we say we're looking for things that people are talking about related to the burden of the disease. So like the symptoms that they're experiencing. And then we also look for the topics that they're talking about related to management. What are they doing to manage their disease, which might be diet, supplements, off-label medications. And here on the screen is a snapshot of the data from the burden analysis. And as you see, conversations about fatigue, tired, sleepiness, they trended really high in this group. As we all know, you know, obesity and hyperphagia are primary concerns within the community. And so this doesn't say anything about the importance of or the priorities of the community. It just tells us that there might be something there that we should dig a little bit deeper into. And so, oops, what's happening? So this is just to give you a little bit of an idea of how we produce those lists. We actually ended up partnering with Dr. Glaze and Dr. Ravana at Texas Children's Hospital. And we asked ourselves, could we start to understand how the community is impacted by sleep issues by further analyzing the conversation data as a starting place. And so Dr. Ravana and Dr. Glaze, they helped us to describe what disordered sleep looks like from a clinical perspective in our population. And so we were able to then train our analytics engine to go beyond looking for things like I'm tired, I'm sleepy, I'm fatigued, to looking for things like head bobbing, loss of balance, narcolepsy, cataplexy. We never share the raw conversation data, so these are just paraphrased examples of what our engine might find and how it might pick out those terms or phrases that would give us some insight into what exactly the community is talking about. And so I think what's interesting is that we started to realize that the community and the caregivers seem to maybe be describing narcolepsy and cataplexy like symptoms, but we didn't have the words. We didn't realize that's what our children were experiencing. And so this was really the starting point for us. And then this is, sorry, again, I'm getting ahead of myself. Oh, why is my, this is again, just to give you a little more depth into the social data analytics. These are just some of the topics that we looked at. So sleep, behavior issues, hunger and weight, and gastrointestinal. And then those concepts included, those are some of the terms that were included within each of those topics. And on the right, it shows you the number of mentions of those combined terms within each of the groups that we analyzed. So then, you know, social listening is a great tool for really just listening to what matters to the community. But then we really wanted to, I don't know why it keeps doing that, I apologize. We wanted to go a step further, and we created a survey, a 72 question survey that we fielded online with the community. 8 of those questions were derived from the Pediatric Daytime Sleepiness Scale, which is a validated instrument for measuring excessive daytime sleepiness in children. But then, as you can see, we generated a bunch of other questions to help us, again, continue to further understand what are the issues, sleep issues that are most impacting our community. 195 caregivers responded, which is incredible. We were very excited about that. Ages of the children range from 0 to 18 years, but the majority of the responses came from caregivers of children between the ages of 5 and 12. 65% reported sleep disordered breathing symptoms, 30% reported narcolepsy and cataplexy symptoms, and 30% reported insomnia symptoms. So this data, this data suggests that children and adults with PWS frequently experience sleep problems, particularly sleep disordered breathing and narcolepsy-like symptoms, including cataplexy. So now I'm going to hand it over to Dr. Glaze, and this is going to keep happening. I apologize. I'm not sure why. And he's going to give you the clinical perspective. So what are they seeing in the clinic, and what does excessive daytime sleepiness look like in our kids from a clinical perspective? So Dr. Glaze, if you can turn your camera back on and take it from here.
Thank you, Maria. First of all, a big Texas howdy from Houston. Thank you all for all the attendees who have joined this meeting. I really appreciate it. I will be talking briefly about sleep with some emphasis on excessive daytime sleepiness.
Dr. Glaze, can you put your camera on, please?
Okay. Well, this is an additional treat for you all. You get to see me. We recognize this problem as an unrecognized problem, or more probably better termed a problem that is not frequently or appropriately thought about in PWS. Could I have the next slide, Maria? And could I have the next slide? So to begin with, I want to go back to Maria's theme. Let's go to the light. Let's go to where the money is. And this slide shows the results of a survey that was made from the Prader-Willi syndrome registry. And the important part of this is that 61% of the respondents endorsed having at least one or more sleep problems. I think it's interesting the number that reported daytime sleepiness, that they were having issues with being too sleepy, having difficulty paying attention during the day. Nearly 50% of the respondents endorsed that. Additionally, I'd like to emphasize nearly 10% of the individuals with PWS reported experiencing what was thought to be cataplexy. In the general population, the incidence of cataplexy, of narcolepsy, is much less than 1%. So a tenfold increase, at least, if not more, in patients with PWS. Also, from the survey, it was observed that 87% of the respondents had a sleep study. You know, in my experience, in the general population, certainly less than 5% undergo sleep studies. So this is an extraordinary number, and I think it just emphasizes the problem that sleep problems are very common in PWS. Of those undergoing sleep studies, nearly 60% had evidence of apnea. That means pauses in breathing occurring during sleep. And the pauses in breathing could either be central pauses where there's no effort, no airflow, or they could be obstructive pauses where there's no airflow, but there's continuing effort, attempts to breathe. So these sleep problems turn out to be very common in PWS. Sleep disordered breathing, sleep apnea is also very common. Next slide. Okay. So the first question that might be proposed is, why should this be? Why should individuals with PWS be at risk for having such high risk for having sleep problems? And I think you have to go back to what Prader-Willi syndrome is about. What are the clinical problems experienced by individuals with Prader-Willi syndrome? What's the underlying mechanisms that are disordered in Prader-Willi? And those indeed will account for the number and frequency of sleep problems that we see in these individuals. And they can be looked at in early childhood, infancy, versus older children and adults with PWS. In infancy, contributing factors to sleep problems primarily include, one, that they have generalized hypertonia, laxity of muscle tone. And that not only involves the skeletal muscles, the muscles of the legs and arms, but also the muscles of breathing, the chest wall muscles, the muscles around the airway that control breathing and allow air to get into the lungs. With hypertonia, decrease tone, laxity of all the muscles, that will lead to problems moving air in and out of the lungs and will lead to sleep apnea, which can be experienced even in very young children, even in infants. In addition, from birth, there's evidence of hypothalamic dysfunction. The hypothalamus is part of the brain that is important in controlling many activities involved in day-to-day life. These include endocrine function, but also controlling and regulating sleep and wakefulness. And so from the beginning, there is dysfunction or disorders of sleep-wake regulation. Next slide. The clinical profile looks different as infants become children and adults, in that obesity becomes a marked feature of the PWS. Obesity is a known risk factor for sleep disordered breathing, for obstructive sleep apnea. So not only do you store additional increase in fat in the abdomen, but also in the neck regions around the airway. And this can lead to blockage of the airway. And it's more of a problem during sleep because muscles typically relax during sleep. And then if you have additional mass, additional problems such as obesity, that will lead to blockage of the airway. Hypothalamic dysfunction continues to be a significant problem in children and in adults. And this means that there's problems regulating sleep-wake cycling, regulating ability to be awake at appropriate times, to pay attention. So this is like the perfect storm. There are many factors due to the underlying problems, underlying mechanisms involved in Prader-Willi syndrome that lead to the increased frequency of sleep problems in these individuals. Next slide, please. How does this compare to the general population? We know in children, approximately 25% of children experience recurring sleep problems, often of enough to bring them to their pediatricians or even to the sleep doctor. In comparison to that 25% number, as we saw in Prader-Willi syndrome, as many as 61%, or 2 to 3 times the number of typically developing individuals for Prader-Willi individuals who experience sleep problems. I think very important, and the reason that we're concerned and the reason we believe something needs to be done about this, including recognition of the problems as well as appropriate treatment, is what is the impact? And I would like to emphasize several areas of impact of sleep problems. First of all, the individual with sleep problems doesn't get a good night's sleep. Getting a good night's sleep is important for proper bodily function in all areas, whether it be endocrine, immunologically function, cardiovascular function. It's important for functioning during the daytime. If you get poor sleep at night, the next day you're going to have problems not only with paying attention, being too sleepy, but other organ systems are going to be affected and don't function in an effective way. Second, not only is the individual with Prader-Willi syndrome affected, nighttime sleep is affected and they get poor sleep, but other members in the family also will be impacted by the sleep problems. And the incidence of poor sleep, the incidence of depression, other behavioral problems is increased in family members of individuals who have significant sleep problems, and may account for difficulties the caretakers have in trying to help their child or the individual with Prader-Willi syndrome. The third factor that I'd like to emphasize is these types of problems, nighttime problems, daytime problems, exist for children without Prader-Willi syndrome, for typically developing children who have sleep problems. But in the PWS individual, they are more of a problem. They're increased. Having underlying neurological problems, developmental problems, means that you're at greater risk for the impact of sleep problems of this type, that they actually worsen already existing behavioral problems, already existing cognitive problems. So it really impacts in that way also. Next slide, please. As a sleep physician, we recognized that the majority of patients with Prader-Willi syndrome are at risk for three types of sleep problems. These include sleep-disordered breathing, so-called obstructive sleep apnea syndrome, chronic insomnia, and excessive daytime sleepiness with features of narcolepsy. And an individual with Prader-Willi syndrome may have one or may have all of these problems impacting on how they sleep, how they function during the daytime. Next slide. We have a number of tools that allow us to evaluate sleep in individuals with Prader-Willi syndrome. These include questionnaires which have been developed and validated to identify sleep problems in children and adults. One of them is shown here. It's called the BEARS, and the letters of the word BEARS refers to the questions you ask about sleep. The B for bedtime problems, E for excessive daytime sleepiness, A for awakenings during the night, R for regularity and duration of sleep. Is the individual getting a developmentally appropriate amount of sleep? And the S for snoring. And this questionnaire can be used by pediatricians, it can be used by specialists. And if the answers are yes to one or more of these questions, it would indicate a need to further investigate whether there's a significant sleep problem. And parents can use it when they're thinking about their children and the individuals with Prader-Willi and see if they are experiencing sleep problems. We also have a validated questionnaire to look specifically at daytime sleepiness called the Pediatric Daytime Sleepiness Scale, and it mirrors a scale that's used in adults called the Epworth Sleepiness Scale. And so there are scales that have been validated to look specifically at excessive daytime sleepiness. Another tool we use is called a sleep calendar, and this is a record of day by day, 24-hour period in which the caretaker records the time the individual is awake, the time the individual goes to sleep, the time the individual goes back to sleep, and does that over a 2-week period. This is a powerful tool that allows you to look at what sleep looks like over a long period of time and gives you a good idea of the regularity of the sleep pattern of the wake pattern. For example, in this teenager, it shows a typical teenage pattern. Going to sleep every night at a regular time, on school nights at about 10, but actually not going to sleep until 1 or 2 a.m. and waking up early to get back to school, resulting in insufficient sleep. However, on weekends, you can see the individual is allowed to go to sleep at what the actual time they actually go to sleep. So they have a delayed sleep phase here. So this sleep calendar, sleep diary can give important information as to the character of sleep. Actigraphy is a watch-like device worn on the wrist, which is sort of like a Fitbit that you can buy at your local Walgreens that records activity, the paradigm being if you're active, you're probably awake. If you're not active, you're at rest or asleep. And this gives a profile that mirrors that of the sleep diary of periods of wakefulness and sleep. And so gives objective data as to how the individual is sleeping, how the individual can maintain wakefulness or not maintain wakefulness during the day. Next slide. Our gold standard is doing a sleep study. And as you saw on the initial slides, many individuals with Prader-Willi syndrome undergo sleep studies. It's a powerful tool for a number of reasons. 1, it's non-invasive. 2, we don't give sedation. We allow the individual to go to sleep on their own, sort of natural sleep. 3, we record them from the time they get in bed to the time they get out of bed. So it's a very long period, collecting data constantly during that period. And there's recording of brain activity, breathing, flow through the nose, the mouth, breathing, movement of the chest and abdomen, oxygen values by a device called an oximeter, the waste gas carbon dioxide measured is also measured. We measure leg movement, we could measure arm movement. We typically video all things, so if there are any unusual behaviors or events, we can go back and characterize them precisely by correlating them with all these physiological parameters. So this is a powerful tool that allows us to characterize sleep, see if it's appropriate, if there are abnormal sleep characteristics, either in breathing, in heart rate, and brain activity, and so forth. This type of study is done typically in the laboratory, in the presence of a sleep technologist. We also have the ability to send the equipment home and do it in the home environment without the presence of a technologist. And we can do this type of study during the daytime to evaluate the tendency to have excessive daytime sleepiness by doing a test called a multiple sleep latency test, which is the recording of a series of nap sessions of 20 minutes duration, during which we measure the likelihood of going to sleep, how long it takes the individual to go to sleep, and 2, what kind of sleep they go into. When we're looking at narcolepsy, do they go into what is called rapid eye movement sleep or REM sleep? So this is, again, a powerful and important tool in characterizing sleep problems and in our understanding of what is going on in sleep in children and adults. Next slide. I wanted to talk a bit about symptoms or clinical presentations of the 3 major types of sleep problems that we see in PWS. Sleep disordered breathing is very, very frequent. Again, early on due to the hypertonia, later is probably secondary maybe secondary to obesity. But in children, it can also be due to enlarged tonsils and so forth, which impact on patency of the airway. The symptoms that we ask about and investigate include snoring, and especially you'll see the snoring, is it loud or not? Is it occurring in certain positions like on the back when it's more likely to occur? We will ask if there have been witnessed episodes by the caretaker or the spouse of pauses in breathing, so-called apnea, when there is no effort or there's some effort, but apparently they're not moving air effectively. We'll ask, does the individual choke or gasp during the night because of airway blockage and trying to move air in and out of the lungs? As a result, the individual, if they're having sleep apnea, may experience frequent arousals from sleep, and so will report having restless sleep, not being able to maintain sleep. And the result of that may complain during the daytime of excessive daytime sleepiness, falling asleep at inappropriate times, falling asleep at school, falling asleep on the job. Young children of school age, actually report the opposite effect. They often appear hyperactive when they experience sleep disordered breathing. And it's almost like they're trying to keep themselves awake by being in constant motion and active and have difficulty paying attention. So those are symptoms that we ask about in reference to sleep disordered breathing. Next slide, please. Chronic insomnia, first of all, the chronic part refers to the fact that difficulty with sleep is occurring over 3 months. And often patients who experience insomnia, individuals with Prader-Willi experience insomnia, have it for months, for years before it's realized and something is done about it. And insomnia can either be difficulty initiating sleep, and problems with going to sleep, problems maintaining sleep, so awakenings throughout the night, or early morning awakenings. And from our experience, early morning awakenings are probably the most common problem in reference to insomnia experienced by individuals with Prader-Willi syndrome. As a result of this problem, the patients don't get refreshing sleep, they don't get a good night's sleep, and so during the daytime, it impacts on their ability to maintain attention, leading to fatigue, or even in some cases, sleepiness, because they did not acquire good sleep, consistent sleep, or a sufficient amount of sleep. Next slide, please. Yeah, thank you. So there are probably many factors related to Prader-Willi syndrome that give rise to excessive daytime sleepiness. Again, by excessive daytime sleepiness, we refer to the tendency to fall asleep at inappropriate times during the day. The problem with maintaining wakefulness during times when you need to be awake, such as school, such as in learning situations, or on the job, so that you can't do those activities in an appropriate way. Things that contribute to excessive daytime sleepiness in the case of PWS include medications. Many of the medications that are received by individuals with PWS can cause sleepiness. There are a few medications, certain behavioral medications, antidepressants, that actually can give rise to insomnia and difficulty maintaining sleep. Problems such as endocrine abnormalities, thyroid dysfunction, obesity has been linked to excessive daytime sleepiness. All of those problems seen in PWS can contribute to excessive daytime sleepiness. In addition, they may have underlying sleep problems, such as sleep disordered breathing. And when it's severe, again, it can be a factor related to excessive daytime sleepiness. Many individuals with Prader-Willi syndrome have a narcolepsy-like symptoms, including excessive daytime sleepiness, sleeping at inappropriate times, difficulty resisting going to sleep, as well as attacks or episodes of cataplexy. Next slide, please.
Dr. Glaze, do you mind if we stop here? And because I really want to make sure we have time to get Justice and Christy's perspective on narcolepsy and cataplexy. So I think this might be an okay place to stop. Is that okay?
Why don't you let me do the next two slides and then...
Okay, we just have a hard stop at 2:45.
Okay. Again, can we go to the next slide?
Yep.
So individuals with Prader-Willi syndrome often experience cataplexy. Cataplexy is a significant sign and seen in individuals with the sleep disorder called narcolepsy. Cataplexy represents episodes of muscle weakness and often occurring and brought on by strong emotional changes like laughter, hearing a joke, or can be brought on by times when you're getting rewards for doing certain things. It's typically characterized by drooping of the eyes, facial drooping, actual dropping, collapsing because of generalized muscle weakness. There can be slurring of the speech, there could be lip smacking and tic-like behaviors in addition to actual loss of muscle activity. Next slide, please. In the case of Prader-Willi syndrome, some additional features that represent cataplexy occur, and these may be characterized by behavioral outbursts or so-called meltdowns, episodes of leaning to one side, not full collapse, but associated with laughter. Again, eyelid twitching, drooling at inappropriate times, gait disturbances with episodes of falling when there's a generalized loss of muscle tone, and then just staring episodes when there's a lack of activity. So having said that, why don't we stop and go on with what you propose to do?
Okay, Justice and Christy, can you come back on? Great, thank you. Thank you, Dr. Glaze. That was really helpful. Christy, so looking back on Justice's life, can you talk about how you think these sleep issues impacted her development? What were the signs or the symptoms that you noticed? And did you recognize them at that time that they were related to sleep? Can you just talk generally about your journey also to get answers and the proper treatments for those sleep-related issues?
Yeah, Justice keeps disappearing, sorry. Yeah, so quickly, so Justice has had sleep issues ever since she was a baby. She would fall asleep in the high chair, especially while she was eating. All the things that I hear parents talking about now, you know, she would laugh and just drop to the floor. She was sleepy. She was so sleepy all the time. So I wasn't sure what it was. It wasn't until she was 5 and we happened to be at the neurologist and he made her laugh and she dropped to the floor. So we were very fortunate, I guess, that he saw this and he did, he wanted to make sure she wasn't having seizures. So he did an EEG right there in the office and then did more testing. We had a ton of sleep studies done where they first were just doing the overnight ones and then they started doing the daytime sleeping ones and realized that she had not just narcolepsy, but cataplexy also. I think because of the narcolepsy and cataplexy, she missed out on a lot of school. She never made it through a whole day. She took naps at school or she came home early. She didn't make it through any like sporting events of my kids. We weren't able to go anywhere. She would come home from school and she would sleep, you know? So I think when we talk about what she missed out on a lot of her education. We had to try to play catch up in the back end with a lot of that. getting her medications was very difficult. We tried many, and when I say many, I mean all medications before we were fortunate enough to meet some wonderful people who introduced us to pitolisant, and that, along with now another medication, has finally got her in a really good place. But it was a trial and error. We tried many medications. Some of them had terrible side effects. Some of them just did not work for her at all. So it was trial and error, but we finally found it, and now we're in a good place.
Great. Very interesting. So Justice, as your mom just explained, you've been living with narcolepsy and cataplexy in addition to PWS. And our work with Trend suggests that many kids might be experiencing similar symptoms, but their doctors haven't yet made the connection to narcolepsy and cataplexy. Can you talk about what it feels like to experience narcolepsy and cataplexy episodes? Is it scary? And how do you think that having narcolepsy and cataplexy have impacted your life?
It feels like I'm tired all the time and I can't focus. It's foggy all the time when I can't take my medication. It was scary at first until I realized and knew what it was. And then I was fine. Narcolepsy and cataplexy has impacted my life a lot. I couldn't function in school, so I would fall asleep a bunch, and I missed a whole bunch of school. But now, since I have been treated for my narcolepsy and cataplexy, I can go to school without falling asleep, able to watch a movie without falling asleep. My mom has more pictures of me sleeping and not than awake.
And we've hung out before, and I've seen this. And also, as I mentioned, my daughter, Sotea, has narcolepsy, and I think she's experiencing cataplexy, but it's not as obvious. So what happens when you have a cataplexy episode?
Your muscles just, honestly, it feels like they just give out, and you're basically not in control of your muscles, so you just drop to the ground.
Are you awake? Do you know what's happening?
Sometimes, but I'm sometimes not. But I can hear everything.
Interesting. And Christy, what's it like for you? I mean, I know that you guys have been, it's kind of been part of your life for a long time. Is it scary for you now? What's it like for you when she has an episode?
Yeah, at first it was terrifying because I would walk into a room and she would be laying on the floor. I hate to say that we're just sort of used to it now, but now we're kind of used to it. I make sure she's safe. And as long as she hasn't hit her head or anything, I just let her wake up as she wakes up. The unfortunate thing is the school doesn't really understand what's happening. So they've called the ambulance more times than I can count and had her, brought to the hospital or whatever. And so now I just tell them, please don't, this is not something that she needs to go to the hospital for every time. So that was very disheartening, just because the school, they had to empty out the classroom every time, this was happening 4 or 5 times in a week. And so it was not just disrupting her learning, but also the rest of the class. So that was very hard.
What about, I know that in the work that we've been doing, we notice people talk about their kids faking falling asleep. Do you think that, did you feel that way? Were there times when you thought, is she, what's going on? Is she just ignoring me? Did you ever think that the episodes that she was having were behavioral?
No, I never thought for Justice that it was behavioral. I know that there are people that I am close with. They did think that it was behavioral, that she was either faking it or trying to get attention or not wanting to be in school or whatever the case was. But when you know your kid and you know that there's something just not right, and you can tell, you can see when people are faking it. Definitely was not faking it.
Thank you. So, Dr. Glaze, if a parent believes that their child might be experiencing sleep-related issues like narcolepsy and cataplexy, what should they do? Who do they contact?
Of course, their first contact is with their primary care physician, their pediatrician. If they don't get the answers then, and they feel their child or teenager or young adult is having sleep problems of any type that we've talked about, they should be empowered. And I think that's the message. You should be empowered to say, no, I need answers to this. I need to see a sleep specialist if the pediatrician can answer or won't do the workup. And they shouldn't be dismissed as faking it, or they just take naps, and children take a lot of naps. So it's important for parents to feel empowered to do that, to help their child, and just as was done here.
Thank you. So we have a couple of questions coming in. First of all, what are the most common treatments for these symptoms? And also this person wanted to know, are there side effects with those treatments? What are they, and how frequent are they?
So we're talking now just about the treatments for the narcolepsy-like symptoms.
Correct, yes.
Traditionally, there weren't any good one drug that would solve all the problems, and combinations of drugs. Some drugs, stimulants, were used because of the sleepiness problem. Other drugs, typically antidepressant-like drugs, were used because of the cataplexy or loss of muscle tone. The effects of those drugs were on REM sleep, on parts of the brain that would give rise to those types of problems. However, more recently, certain drugs have been approved that address both issues of sleepiness and cataplexy. And there are two varieties. One, Xyrem, is given at night, so it helps consolidate sleep at night and leads to improved wakefulness and attention during the daytime. And it will also help the cataplexy. The other drug is approved in adults called pitolisant, and it is given during the daytime because it actually has direct effect on wake-promoting centers in the brain. And so its action is a little different from the traditional drugs and from the Xyrem. But I think what you heard was many times the traditional drugs aren't very effective for Prader-Willi syndrome and are associated with potential side effects. I think this comes back to, one, while the symptoms are similar to narcolepsy, the reason for the symptoms due to the Prader-Willi syndrome might be different from what we think of as a narcolepsy, which is thought to be an autoimmune disease. Because of that, we need to be investigating and looking for drugs that directly affect this problem in Prader-Willi syndrome, not merely that are used for narcolepsy. And that's why awareness of the problem and awareness of the need for further research is important to help individuals who have Prader-Willi syndrome.
Thank you. Christy and Justice, do you want to talk about what treatments have worked for you? And a follow-on to that question was about whether or not the treatments can increase anxiety. Have you had any experience with that? Feel free to share as much or as little as you want. Oh, you're on mute. I think you're muted.
Sorry. So like I said earlier, we tried many medications, like everyone possible, Vyvanse, you name it, we tried it. Provigil, she had a terrible reaction to. So we almost seriously were about to give up and when we found pitolisant. And it has not, I mean, it has changed her life. If you ask Justice, what does it feel like now that you have pitolisant?
It feels like I'm a part of the world versus in the world. Because I was always just, it was always just foggy. I couldn't function. So I was in the world, but I was always sleeping, so I couldn't be part of the world.
So that's the best explanation that we
That
have.
is an incredible explanation. And what about anxiety? Do the medications increase anxiety, or do they tell us about that?
So because I told us when we started and we were in a study sort of, right? So we were just taking it, and when we got too high, it did increase anxiety. So then we backed off and that went away. She's been really just fine so far, but
Great.
we did have to be careful because when we did get too high, it did increase her anxiety.
Great, thank you. So someone wanted to know the name of the watch device. So that's an actigraphy watch and how it's used. And so correct me if I'm wrong, Dr. Glaze, that just it's worn on the wrist like a watch, and it basically assumes that you're sleeping when you're not moving, and it assumes that you're awake when you are moving. Is that correct?
That's correct. It's called actigraphy because you're measuring action, or as you said, activity, and that's the paradigm used. And they are frequently used by sleep medicine specialists in order to give a profile of sleep over a long period of time. So you can wear the watch every day for a couple of weeks, and it will continue to record and give you that information.
Great, thank you. And another question for you, Dr. Glaze. Someone was asking if physicians recommend melamine to help with sleep at night.
I'm sorry, what medication?
It says melamine. Maybe they meant melatonin.
Melatonin?
Yeah, probably melatonin.
Melatonin is frequently given, especially to children with developmental disorders. It seems to be helpful because they may have an underlying melatonin deficiency and sleep regulation problem. It's not going to be a drug that you would use for the problem of excessive daytime sleepiness or narcolepsy-like symptoms.
Okay, thank you. And the next question is, if a tween does not have typical sleep apnea symptoms, should they still get a sleep study to rule out apnea, or do PWS individuals have the same or less symptoms of apnea? Go ahead.
So one reason we see patients and ask questions and evaluate them before doing the sleep study is to find out if they need it. If they endorse symptoms which I went over, such as snoring and pauses in breathing, we would do a sleep study. If they don't have those types of symptoms, I don't think there's any reason to do a sleep study. I wanted to make one further point. While if you have moderate to severe sleep apnea, often it results in daytime sleepiness, it is not the cause of the sleepiness that we're talking about, of the narcolepsy-like problem, because we see patients who have little or no obstructive sleep apnea, but are still very sleepy during the day, still have difficulty paying attention during the day. So those problems should be looked as separate issues and addressed appropriately, and not just discount everything. Well, they're obese, they have sleep apnea, that's the end of the story, because it's not the end of the story.
Thank you. And what about using oxygen for sleep apnea? Is that something that's used?
Well, if you have obstructive sleep apnea and you don't move air into your lungs, I don't know how the supplemental oxygen would work. Typically, we do that in the case of people who have underlying existing lung problems, cardiac problems, infants, but that typically is not our first line treatment of obstructive sleep apnea. We use a device called a CPAP device. It delivers pressure to keep the airway open.
Great. So I guess this is a question kind of directed at all of us, and we kind of you touched upon it, Dr. Glaze, but it was directed at you, Christy, as a parent of a child with PWS. Do you think that all kids should have regular sleep studies, or only if the issues are visible? And I don't know, I'm kind of putting you on the spot with that, but it was directed to you. Do you have thoughts on just getting sleep studies and being proactive?
I do have a lot of thoughts on that.
Okay.
I think that most of our kids with Prader-Willi have sleep-related issues, and I think that they're undetected a lot of times. So getting a sleep study done, I think, is critical. You know, I mean, it's not harmful in any way to have a sleep study done, so it's not like, you know, it's kind of annoying. But other than that, it's not going to harm your child at all. So I would highly recommend everybody should get one.
Dr. Glaze, are there any tips that you have in terms of getting a sleep study? I mean, I recall, you know, all of our kids who go on growth hormone, they've had a sleep study or 2 or 3 at some point in their lives. And I know that often they just check for apnea. Should we be requesting specific tests to look for some of these other things? Oh, you're on mute.
I'm not on mute.
Oh, sorry.
Putting together an answer to your question. Again, I go back to, if you're concerned about how your child is sleeping or not sleeping, breathing during sleep or not breathing during sleep, or falling asleep at school repeatedly, if your child is over 6 years of old, they should not be taking naps. If they're taking naps, then your child is too sleepy or is having breathing issues. Your physician, the primary care physician, or a sleep doctor needs to investigate that. One of the ways of investigating is doing a sleep study. As I said, it's a powerful tool. It can give you a lot of information. And so, yes, you should be requesting or demanding that this problem be investigated.
Thank you. We have a couple minutes left. There's one more question in my queue here, and asking if our social listening, through our social listening, what's the most commonly undiagnosed or misdiagnosed sleep issue that we think we're seeing? I would say, from my perspective, personal and from the social listening, is that we still need to understand the cataplexy. And we continue to see people talking about their kids collapsing and tripping and dropping things. And I know that that's something that we are constantly thinking about in our family. Our daughter doesn't have a diagnosis of cataplexy, but you know, I think that's even more so than just narcolepsy broadly. That's an area that seems to still require a bit of awareness in terms of what that looks like for our kids.